Lung transplant has been developed as a treatment option in CF over the last 30 years or so. The first lung transplants for CF were done in the 1980s. And in those early years, very few were done, and the outcomes were not very good. Over the last 2 decades, the number of transplants performed for CF and the outcomes, the survival rate of people who've gotten transplants, has improved significantly. So lung transplant has become, for many patients, a good treatment option. The challenge for us is knowing when to pursue lung transplant. And in general, we think about lung transplant as something reserved for patients with very advanced disease. So those patients whose disease trajectory has been downward despite maximal medical therapy. In many ways, I think of it as a plan B, that if the lungs fail, transplant becomes an option to prolong life and improve the quality of life. We all know that with advances in care, the trajectory of lung and nutrition in CF has in general improved dramatically. So new therapies from pulmozyme to hypertonic saline to most recently CFTR modulators, we have new therapies and improvements in function. Unfortunately, still as patients age, lung function tends to progress, and there tends to be a downward trajectory or a decrease in lung function over several decades. So it's important for patients and families to understand where they are as individuals in the course of their lung disease. Do they have very good lung disease with preservation and a high FEV1? Or is their FEV1 changing over time such that they need to be really concerned? As we think about advanced lung disease and lung transplant as a treatment option, it's helpful to consider what the survival of individuals with CF is below certain levels of lung function. So recent studies by Kathy Ramos and Chris Goss and others have shown that when the FEV1 declines to less than 30% of predicted, the median survival, that is the average or midpoint survival for a cohort of patients with FEV1s under 30 is 6.5 years. It's important to know, however, that there's a very broad range there. We know that about 10% of patients with an FEV1 under 30% die each year. So while some patients with that level of lung function may live 10 or more years, some patients may live a year or less. That statistic gives us some insight into the role and timing of lung transplant. As one can imagine, when you have near normal lung function, the quality of life improves dramatically. So the daily cough generally is gone. Much of the burdensome respiratory treatments like aerosols, oxygen use, airway clearance, those are not required after transplant. So patients find that the pill burden is high, but the aerosol treatment burden is very low. So in the combination of improved lung function and a less burdensome treatment regimen, most patients enjoy a marked improved quality of life. And many are able to return and finish school, go to work full time, have patients who've gone hiking at 12,000 feet, traveled the world, and done lots of things that they probably would not have been able to do had they not undergone a transplant. The goal is to find that sweet spot where the risk of transplant is lower than the risk of having your own severely diseased lungs. So we like to find what we call the transplant window, where the benefit-risk ratio favors transplant rather than keeping and trying to push on with the native CF lungs. That decision is really a mutual one between the transplant program and the patient and family. The transplant programs generally make a recommendation but never dictate it. The patient has to decide that they're in a place where they're ready to pursue transplant, ready to make the sacrifices and do the things that they need to do to get through transplant and do well afterwards. Referral for transplant is a challenging process, and it's something that the CF Foundation has established a working group and developed some guidelines to help develop a consensus, make recommendations to the community of providers, patients, and families so that we make the right decisions about transplant referral. The goal with referral is to provide patients and families with education about transplant as a treatment option. So the first step is the CF provider having a discussion with the patient and family about what's involved in lung transplant. It's very much an educational process. The second phase is records are sent to the transplant center and referred and reviewed by the transplant center so that they can make a preliminary assessment about whether transplant is appropriate or not. We find, unfortunately, that there are a small percentage of patients who are not candidates for transplant. Sometimes those are apparent just from medical record review, and so the referral may stop at that first phase of record review. The next phase in the referral process or evaluation process is a formal evaluation where patients go to the transplant center. They usually have 3 to 4 days of outpatient testing with a number of consultations with specialists, including the surgeons who were involved in the procedure, a social worker, nurse coordinators, a dietitian, and a medical CF or pulmonary transplant doctor. At the end of that evaluation process, the transplant team gets together and they review all the testing and opinions of the different team members and make a recommendation. One of the things that we've learned, unfortunately, is that some patients are referred for transplant far too late. We know that patients sometimes die in their home CF center without ever having a discussion about lung transplant. So the recommendations that we're making are to refer early. We want patients to learn and understand and have discussions about transplant maybe as early as when the FEV1 is under 50% predicted. And then a much more serious discussion when the FEV1 is under 40% predicted. We know from registry studies that the survival of patients with CF who undergo lung transplantation has improved significantly over the last 2 decades. Unfortunately, that survival is far from perfect. The median survival in the recent registry data is about 9.5 years. This is an important number to keep in mind, in part because we know that with patients having FEV1 under 30% predicted, the median survival is 6.5 years. So many patients, when the FEV1 is around 30 or lower, reach a point where the survival with a lung transplant is higher than the survival of keeping the CF lungs as is. The challenge we have is in predicting when the perfect timing is, and there is a window there that is oftentimes, unfortunately, difficult to predict. But we know that we are learning more about transplant. We think that survival is improving over time. So my recommendation to patients is to really maximize their medical therapy and put transplant off as long as possible within a safety window so that we can develop better treatments and have even better outcomes for lung transplantation. Lung transplant really is oftentimes best considered as a heroic intervention. In order for patients to undergo a transplant, we have to identify an organ donor. Those are usually brain dead. The organs have to be removed and then replaced into the lung recipient. So the operation and the surgical complexities of that vary, but are typically quite prolonged. Many patients will be in the operating room for 6 to 8 hours, and the period of recovery after transplant is generally 2 to 3 weeks in the hospital, with weeks to months of rehabilitation after that. So for this reason, we don't think about lung transplant as an easy or simple intervention. It's very complex. It requires a highly skilled team of surgeons and medical doctors in order to optimize and make the most of the procedure. As you can imagine, that takes a big commitment from patients and terrific family support to make that work. So we expect that patients understand what the process is about, and in particular understand what the care requirements are going to be afterwards. Patients have to get through surgery, they have to get out of the hospital, and then they require routine care in the transplant program, very much similar to the routine care that they get before transplant in their CF center. So it's critically important that patients are able to understand the commitment and the sacrifices they have to make in order to optimize their survival and quality of life after transplant. It's important for patients and families to understand that the complications after transplant are numerous. First is surgical complications. Those have dramatically decreased in the last several decades as the surgical techniques have improved. Surgical skills have improved, the anesthesiology support in the operating room has improved, and so much of the improvement we've seen in survival after lung transplant is related to improved survival in the first year. We know that approximately 90% of patients survive at least 1 year after transplant, so most of those surgical complications can be overcome. Long term, the major complications of transplant and the significant ones that reduce survival are rejection and infection. Rejection is a common process after transplant. It's usually treatable and responds to medications in its acute forms, but it is a known complication and can result in a loss of lung function and in symptoms. Infections occur frequently in patients who've received transplant, and much of the post-transplant care in the clinic is to identify infections early and treat them aggressively to prevent them from becoming life-threatening. Our strong recommendation is that everybody under 30% predicted, if they're interested in transplant, should undergo a formal evaluation. The goal there is to basically create what I call a plan B. Plan A is to do okay with your current lungs and treatments. But if something catastrophic happens, if your disease progresses and you end up hospitalized and on more oxygen, requiring more intensive therapies, you want to have a plan B, an option that will prolong life and improve survival. So I think the important point for patients and families to remember is that early referral, early discussion, as scary as it may be, is critical to not losing out on the opportunity for transplant as a life-sustaining treatment.